Mm,
Uh,
not
once I
clear.
will, once I will check the net internet, sir.
That can be due to Zoom problem, I think. So sometime there will be lag. So okay, no problem.
Okay, sir. Okay, okay.
You can check whether the slides are moving forward or not.
Okay,
Hello,
sir.
sir. Hello? Hello?
Dr. Baishak, one more moderator yet to join. Join.
Okay.
If he's taking some time, then we'll start in 2 minutes.
Okay. Am I audible now, sir?
Yes, yes. Okay, some network issue, I think. So, Dr. Ramkrishna, can we start? Dr. Ramkrishna?
यस सर शुरू कर रहे हैं.
Yeah, Dr. Baishak, you can introduce yourself. Dr. Soumya will join in few minutes. Then Dr. Dipti, you can present. Okay,
Okay,
go
sir.
ahead.
Yeah. Good evening, students. I am Dr. Baishak Renuji. I'm a consultant working in Kochi, Kerala. So we'll go to the first case discussion I'm attending this time. So let's start.
Yeah, Dr. Dipti, go ahead.
Good evening, sir. Good evening, everyone. Today, we are going to present a case. A 52 years old male, G. Saidulu, former by occupation, resident of Guntur, came with chief complaints of hoarseness of the voice from 2.5 years and slowness in the activities related to left upper limb and lower limb from 2 years, tremulousness of left upper limb from 2 years, bladder disturbances from 1 year. Coming to history of presenting illness, patient is apparently normal till 2.5 years back. Initially noted hoarseness in the voice from 2.5 years. Along with it, he also noted attendance, mainly by attendance, noted slurring. Initially, his speech is able to understand, but now unable to understand few words. But after multiple attempts of repetition, the attendants are able to understand what he is trying to tell, which is appropriate to the situation. No history of any straining quality of the speech, no history of any jamming of letters in words, no history of any difficulty to produce what particular syllables.
Okay, so what do you think? We'll
Slowness
assess
in
the
the
first, we'll assess the first symptom. So first symptom is hoarseness of voice. So what
Okay,
do you
sir.
think the
Okay, sir.
localization may be?
Yes, sir.
What is the phenomenology and what are the localizations?
Either vocal cord palsy or
Okay.
recurrent laryngeal no palsy.
Okay.
Hello, sir.
Yeah. Anything else you want to add? Because you told it is hoarse, not just
Because there
hoarseness.
is slurring as well.
Yeah.
Yes, sir.
Yeah, slurring is also there. So
Uh, Slurring is there, so dysarthria is present, but I am unable to assess the type because they are not giving any history of
okay.
straining quality or jamming.
Okay. Many
Hello,
times you
sir.
will not be. Yeah. Am I audible? Hello.
Yes, sir, audible,
Yeah.
sir.
Yeah. Many times you may not be able to get much details in history, especially for dysarthria. Especially in Indian patients, difficult to get. We will get only textbooks till we can get all those things in history. Most of the conditions, this is a history. So it's not just hoarseness. There is hoarseness plus slurring.
Yes, sir.
Hoarseness, hoarseness means what all things you want to include. Hello.
Hoarseness due to my hello, sir.
Yeah.
Hello, sir.
Yeah. I audible.
Hoarseness
Continue.
might be due to yes, sir.
Yeah.
Vocal cord palsy or recurrent laryngeal nerve involvement,
Okay. It can be. If
as
it
there is
is.
slurring as well, be at the nucleus level.
So it you can localize from below downwards. It can be a muscle. It can be neuromuscular. It can be nerve. If it is nerve, it can be
Okay,
the
sir.
culnar or vagus, or it can be from the brainstem, because basically it is a dysarthria. It is not
Okay,
language
sir.
problem. So you're not considering cortex. So if it is fluctuating,
Okay,
you
sir.
can still think of a possibility of a neuromuscular also.
Yes,
I
sir.
mean, what about Larry? I mean, in nerve, whether it is a culnar or vagus, what do you think? If it is an individual nerve,
What, sir?
if it is an individual nerve, do you want to consider entire vagus trunk or you want to consider the culnar nerve? Or whether it is an element or human symptom, basically hoarseness. Hello, am I audible?
Element symptoms, sir.
Yeah, element. Okay.
Yes, sir.
Okay. So you want to consider this as an element syndrome. So will you consider hoarseness as, in this case, you want to think about which part of the vagus, whether it is the entire vagus or in the cranial part, or you want to think of in the neck, or you want to think about the I mean, the laryngeal nerve, if you're considering nerve. Suppose a patient came to hoarseness since 5 days. So you want to localize where
Yes, sir.
based on this history. So how will you differentiate this part of vagus involvement? Okay, so the vagus when it descend downwards, it gives branches to the palate. It gives branches to
Superior
the pharynx.
laryngeal and
Yeah, just
I,
understand it gives to the palate. It gives the pharynx. It
mm,
gives the larynx.
yes, sir.
So if it is the
Mm.
trunk or the origin of the vagus or the brainstem is affected, all three should be involved. So because of palatal involvement, they will have nasal regurgitation.
Yeah,
Because of
nasal
the
regurgitation.
yeah, because of pharyngeal involvement, they will have difficulty in
Soft
swallowing
pen.
or
Swallowing.
aspiration. And if it is laryngeal involvement, it is they will have hoarseness or diplophonia or whatever it may
Hoarseness.
be. So
Okay, sir.
if it is isolated larynx, suppose a patient doesn't have dysarthria, if it is isolated larynx, you can think of recurrent laryngeal now, right?
Okay, sir.
If it is above,
Yes,
there will
sir.
be all the three components involved. If the ganglion, from the ganglion, one branch gives a palate and another branch gives a pharynx. So if it is isolated pharynx, it can be neck also. If it is pharynx plus larynx plus palate, you can think of a higher lesion. If
Okay,
it
okay,
is
sir.
either palate or pharynx alone, you think of a lesion in the neck. If all three, it can be higher or in the neck. If it is only larynx, you think of recurrent larynx. But here slurring is also there. Slurring means it is not just RLN or recurrent larynx now. There is something extra might be involved because usually when you have vocal cord involvement, you won't get slurring.
Yes, sir.
Slurring means you have difficulty in articulating. So how usually you will articulate by using the sound coming from the vocal cord is articulate by using the other muscles of the brainstem. So it may be something involved in the brainstem or multiple cranial nerve, or it may be a proximal vagal involvement. It is the upper part is milder involvement and lower part is dominant involvement. But over the 2.5 years, if it was a mild involvement in the upper, they should have at least some nasal regurgitation or something. So that is not
And,
there. So it is
but
it
there
is
is
more.
no history of nasal regurgitation, sir.
So you can think it as two syndromes. One is hoarseness, and if slurring is definitive, you can think something more than laryngeal now. Something
Okay, sir.
more than it should be something more than RLN from the history itself, because there is slurring also is there. Okay,
Okay, sir.
yeah, and there is
Yeah,
no cortical sign.
Dr. Soumya also joined. I welcome her. Continue,
Yes, sir,
please.
yes, sir. I have also joined, sir.
Welcome, ma'am.
Okay.
Thank you, sir.
Good evening, ma'am.
Ma'am, we were discussing the first symptom. She had hoarseness since.
Noted hoarseness in the voice from 2.5 years. Along with it, they also noted slurring. Initially, it is able to understand, but now they were unable to understand few words. But after multiple attempts of repetition, the attendants are able to understand, which is appropriate. No, but there is no history of any straining quality of the speech, no history of any jamming of the letters in the words, no history of difficulty to produce particular syllables.
Okay. Can you differentiate between this, whether this is a speech disorder or a language disorder, or both are there?
Uh, Speech disorder, madam, because a language attendants are telling it is appropriate. He is speaking appropriately only, but the thing is they are unable to understand.
Okay. So, I mean, whenever you are just giving the history of this speech disorder, we must differentiate at the same time that we are not dealing with the language disorder or the combined thing or whether an isolated thing. So, you have to ask that whether the patient is able to form full sentences or not. I mean, the language history that we take, whether he is using a word which was not in the language, and the most important thing is naming. Okay, all the
Okay, ma'am.
aphasia they have a naming involvement, except
Ma'am, I didn't get you. Can you repeat, ma'am? One second.
yeah, all the aphasia they have a naming issue. In all the
Okay.
aphasia, naming is impaired, except what? The pure word deafness. That is the only aphasia that is
Okay.
does not involve the naming problem. So at the same time, when you are telling the history of a speech disorder, describe the full thing that sir told. The this is like that the speech problem, and along with same time you have to differentiate. We are not dealing with a language problem as well. Okay,
Okay, ma'am.
and there is a hoarseness, and along with that there is a slurring. So that means this is not only the laryngeal problem. Not only the
Yes,
vagus
ma'am.
nerve is involved, slurring is there, so that means this is a problem of articulation. Okay.
Yes, ma'am.
Okay. Continue, please.
And how will you classify? I mean, you know the classification of dysarthria, right?
Yes, sir.
Mayo Clinic classification. Examiner may ask it, you carry it around by that.
Okay.
Okay.
Sir,
Okay,
shall I
we'll go to
tell
next.
or continue, sir?
We'll go to next symptom.
Okay. Slowness in the activities related to left upper limb and lower limb from 2 years. He is able to hold the glass of water and drink it normally, able to mix the food and bring it to the mouth normally. But the complaint what he is telling is he is taking more time when the activity is being done by the left hand when compared to the right. While wearing the lungi, he holds with the left hand and makes the pleats. Previously, he used to make the pleats with the left hand, but he started using the right hand because it is taking longer time with the left hand. No history of difficulty in wearing the shirt over the arm or combing the hair. No difficulty in buttoning and unbuttoning the shirt. Able to mix the food and bring it to the mouth without any smearing over the face.
Okay, can
Able
you?
to insinuate lower limb complaint also. I
Yeah.
will finish, sir.
Yeah.
Able to insinuate foot into the chapel, but when compared to the right side, he is taking longer duration with the left lower limb. And he also complaining that he walks with small steps. Compared to the right lower limb, he is taking small steps with the left lower limb. No history of any slippage of the chapels. Able to climb up and go downstairs, but taking longer duration. Able to get up from the lying down from the lying down position into standing without any difficulty, able to roll over in the bed. No history of any sensory involvement complaints. Right? Slowness.
Can you explain the symptoms?
According to patient, what he is telling me is all the activities related to the left upper limb and lower limb he is able to do without any difficulty, but taking longer duration. So
Okay.
might be due to spasticity increased in tone in the upper limb and lower limb rather than weakness.
Yeah. Or even a dexterity loss.
Uh, might be, sir. If it is dexterity, buttoning, unbuttoning, these complaints also he should tell difficulty. But
He is having difficulty in wearing the lungi. If
making
you're
the
thinking,
pleats, sir, only making the
yeah.
pleats.
If you're thinking he has difficulty only making the pleats, but he is able to do buttoning and buttoning, everything else is normal. Anything else you want to consider?
He's not telling difficulty, sir. He's taking longer duration.
Okay, it is actually difficult only, no? So what else you want
I
to
said,
consider?
okay. Okay.
What else you want to consider? What else other than the slowing weakness? Because it is not there for other. Yeah, one can be apraxia.
Okay,
Anything
sir.
else? It is very task specific. So anything else? It can be some involuntary movements happening in the hand also. Can be a task specific dystonia or tremors that also can occur. Even though
Okay, sir.
you are not getting the history, it may be that also because for the patient it will be difficulty. He will take time.
Okay, sir.
So that also can be there, but you can ask the questions whether during the movement, whether you are getting any posturing, any involuntary movements, or whether the hands
No,
are not going.
no history of any involuntary. Actually, no posturing, sir. Involuntary movements, tremulousness is present, sir. But
So it is basically either increase in tone or change in the tone, or more likely to be slowness. Okay. So what is bradykinesia, hypokinesia, akinesia?
bradykinesia is slowness, sir. Hypokinesia is decreased movement. Akinesia, no movement.
How will you differentiate it in your tap test, finger tap?
In bradykinesia, there will be pauses, sir. Hypokinesia, amplitude will be decreased.
Okay. When amplitude is decreased, it is bradykinesia. Slowness can occur even in human lesions.
Okay, sir.
In human lesions, sometimes slowness can occur because of depression, severe depression. It can occur in severe hypothyroidism. But if the amplitude also decreases, then it is bradykinesia. Akinesia
Okay,
means
sir.
no movement.
Yes.
Okay, one more thing also, doctor. When we are taking the history of this lower limb bradykinesia or the lower limb decrease movement, actually the patient doesn't give that much detailed history. So this seems to be the examination finding that should be told, like that he is moving his left lower limb less than the right lower limb. Better to say
Okay, sir.
that the patient attendant said that they are dragging their limb or they are just
Dragging
having
is
a
not
pronus.
there, ma'am. That's why I,
Yeah, actually, I
Then
want to
just
ask you that. Why, how come you can tell that when one limb is step is a distance between two limbs? How will you tell that if
yes.
one limb is reduced, you cannot tell it a step, no?
yeah.
Okay.
You have to, the patient is not moving one leg, that looks like dragging only, no? Cannot tell it
Mm.
a short step. Short step is when both the steps is low, both the foot is not moving much, you will get short steps. There's a
Okay,
distance
sir.
between the each foot. When only one foot is not moving, he will be moving the right foot, and the left foot is moving little. It on appearance it is dragging,
Okay, sir.
right? When the both foot is there, you can call it as step. That same like madam was telling. This much patient won't tell. For the patient, it will be dragging of the lower limb.
Okay, sir.
You can keep that, no problem. It can be human, it can be extra, but you don't know. Your examination only, you can tell what it is. But whatever
Okay, sir.
patient, you can keep it. Because you can never tell in history the steps of one limb is low. Because
Okay,
one
sir.
limb
Okay, sir.
step cannot be short. Short step is distance between the two foot.
What he's telling is he's unable to wear as fast as like in the right lower limb. He's unable to walk with the left lower limbs.
Yeah,
So
that
I
you can
could
tell
not.
the left. That is actually looks like dragging. When he walks, it looks like dragging only. This technically,
Okay, sir.
it may be bradykinesia. So we don't know. We upon
Okay, sir.
examination, you may get something else, or else a patient may have subtle human features. You have to take whatever comes in the history as it is and try to
Okay, sir.
explain
Okay,
it.
sir.
Yeah, you can tell even the same way. The one leg drags behind the other, or he drags. Dragging. See, when you put the word dragging in the history, that doesn't means you are wrong. That means it can be. It's a symptom what patient is telling. You can explain during the history taking as it is. It may be human. It may be extra, but you can tell anything. But at the end of the examination, you are not finding any human findings, and you're finding bradykinesis. That was because of bradykinesis, an increase in the tone.
Okay, sir.
Okay, please continue.
Yeah. Next page.
Hello, ma'am.
Yeah, yeah, please
Okay.
continue. Please continue. Yeah.
And about wearing the slippers, you told something. Yeah.
No history of any slippage, I told, sir. And while insinuating, he's taking longer time with the left lower limb when
So
compared to the
what all things it can cause like decrease in the difficulty in initiate foot into the chapels.
one thing weakness of the foot muscles, sir. The
Okay.
other is spasticity.
Okay. So initially he has to lift the leg and keep it on the slippers. Suppose he has ataxia, cerebellar ataxia, he will have difficulty to guide. Once he
Yes.
place the foot into the slippers, then he want to use the small muscles, dexterity and tone. If somebody has an increase in the tone in the right lower limb, he has a severe adductor spasm, they will not also again have difficulty. So if you even if you are not putting that statement in the history, these all things it can be possible you can keep. Even sometimes, suppose he has involuntary movements happening while he is doing that. That also will be like choreus there. The
Okay, sir.
patient feeling that he has difficulty. For him, it may not be that much symptom. Her problem will be wearing the slippers. Okay, so I mean you have to keep all the possibilities open. So you just have to
Okay, sir.
think that what happens like in front of you, the patient is going to wear the slippers. What all things can occur?
Mm. Spasticity, dystonia, foot dystonia.
Any involuntary
Mm.
movements, any
Mm.
Okay,
involuntary
sir.
movement, increase
Mm.
the tone, dexterity loss, small muscle weakness, all these can occur because
Okay, sir.
first step is lifting the leg. That requires power as well as normal tone, and then you have to guide the feet into the slippers. That requires proper cerebellum and without an involuntary movement. Suppose it is having chorea, dystonia, or some myoclonic jerks, he will not be able to do that. So now he it has to be normal. Then he has to glide the foot forward. For gliding the foot forward, you need the dexterity, normal tone, and small muscles,
Yes, sir.
and even the long flexors.
Yes, sir.
Okay. Okay. Nothing. Just you have to think of that moment. What all steps are happening? What all muscles and what all things can occur during that. Whatever mode or
Okay,
moment it may.
okay, sir.
Yeah.
Complaining of stiffness in the both the left upper limb and lower limb while walking. This complaint is given by his son. While walking, trunk is bent towards the right side, but no history of any dragging of the left lower limb or wearing of the left chappal. No history of any fall, no history of any gait initiation difficulty or struck to ground feeling while walking. Complaining of tremulousness of left upper limb involving only fingers from 2 years while holding a glass of water and bringing it to the mouth, not present in the rest and sleep. This tremulousness is say all through the moment it is same, not increasing his telling while bringing it to the mouth.
Okay,
Okay.
so
Can you?
analyze the symptom. Yeah, yes, sir.
Yeah, ma'am. Continue. Same only analyze.
Hmm.
Sir, continue, sir.
No,
No,
first
no, just
that slide you analyze the symptom. Yeah.
Complaining the stiffness of both left upper limb and lower limb. It might be due to spasticity or rigidity.
Okay.
While walking, the trunk is bent towards right side. Posturing, abnormal posturing of the trunk.
Okay. He already has difficulty in moving the left lower limb. The last slide you were telling the steps
Mm.
are short, so there will be dragging. So always be careful when you're putting
Okay,
opposite
sir.
statement.
Okay, sir. Okay, sir. No history of any fall, no history of any gait
So
initiation
what do you think
difficulty.
that's that? What do you call that? Bending of.
Trunk bending towards right side.
Yeah.
Sir, sign name or
No,
any
what do you think it is? What is the phenomena
dystonia?
of the truncal muscles?
Yes, sir.
So, so what do you tell the phenomena?
Dystonia,
Pleurototonus.
sir.
Pleurototonus. Deviating one side.
Neurotones.
Yeah.
Okay, sir.
And camptochromy is
Flexion, extend,
so anterior is
flexed
camptochromy.
posture, sir.
Yeah. Anteriorly flexing down is camptochromy. So
Mm.
what do you think it may be? What all things?
Due to dystonia of the truncal muscles, sir.
Okay. So what are the things you want to consider? You are already discussing. He had some slowness on one side. He had hoarseness. He had some difficulty on the left side. Any other sign you want to tell? You know it. Any syndrome? Any name syndrome? PISA syndrome.
PISA sign, sir.
PISA sign or PISA syndrome?
Okay, sir. PISA sign,
Yeah. So that is seen in usually in.
MSA P.
Yeah. Okay. So it is a truncal dystonia on towards lateral side. There was a background history of some slowness on one side, and there was hoarseness. So it may be a PISA syndrome. Okay, fine.
Okay.
Ma'am, anything to add, ma'am?
yeah. Just please tell me that how can you differentiate whether this is a truncal dystonia or whether you are actually dealing with I mean, what other history? It's only in the walking. So other things should also be asked. I mean, what is the
Okay,
condition in
in
the
sitting
sitting or
position and
yes,
in
lying
supine
down?
position.
Yes, in lying
In
down or in
sitting
the
position also there is some truncal deviation, ma'am. In supine it's not there.
and how will you differentiate that the whether this was from the scoliosis or it's a new any dystonia that patient is developing?
Because previously it is not present, now it is
So
present.
that has to be just given that the patient is now developing a truncal bending whenever he is walking towards the right side, and it is present as well as on the sitting position also, but
Yes,
absent
ma'am.
in the lying down. And along with it, any other dystonia is there or not? Whether he is developing some limb movement at the same time, or some neck posturing, or some hand dystonia. So that should also be asked at the same
Okay,
time
ma'am.
only.
Okay, ma'am.
Okay.
Okay.
Because if this PISA syndrome is very common to be in MSH, so these are also these patients also have this enterocolis. So you should ask them that when their patient lie down.
While
So,
walking, there is two-put posture, madam.
no, no, I understand that while walking
Okay,
is a
ma'am.
strict posture, but at the same time, when you should ask them that when the patient lies
Okay,
down,
ma'am.
whether he is able to touch his head to the this bed or not, or whether he keeps it in the front position, or is there any
Okay,
change in neck
okay, ma'am.
position as well.
Okay,
So at the
okay, ma'am.
same time, whether the patient is having other dystonias or not, if there is no other timeline or no one is developing data, you should tell that at the same time. Okay.
Okay, ma'am.
Okay. Yes, please. Next symptom.
And one more thing, and androcolus and retrocolus seen in visual conditions. Like you told the Quissa syndrome where you think of him
Yes,
as
sir, yes, sir.
androcolus.
Androcollis in idiopathic Parkinson's disease and MSA as well, sir. Androcollis.
Retro?
Retrocollis in PSP, progressive
Yeah,
supranuclear palsy.
retrocolus and PSP. Yeah. Okay,
No
continue next
history
thing.
of no history of any falls or no history of any gait initiation difficulty or stuck to the ground feeling while walking.
Okay, come to tremulousness.
Complaining of tremulousness of left upper lip involving only two fingers from 2 years onwards while holding a glass of water and bringing it to the mouth, not present
So
in the rest and the sleep.
this tremulousness was not there in any other activities, only for
No,
glass.
only anything, any object while holding with the left upper limbs.
Okay. That you have to specify because otherwise it is a
Okay,
task
sir.
specific.
Yeah.
Okay, okay.
One more thing. You said that tremulousness is only in the fingers. Holding a
Yes,
glass,
ma'am.
I mean, this
Yeah.
is a use of a median nerve. It's a large muscle. You won't have a tremulousness in fingers. Are you getting what I'm asking? I'm just saying
Yes,
whether
ma'am.
we are
Yes,
dealing
ma'am.
with this myoclonus or want to say that there is a tremor.
Tremulousness is only present, ma'am.
Tremulousness was at the level of wrist or at the level of fingers?
Fingers, ma'am. Fingers.
Fingers only. So only fingers. I mean, only while he was holding an object.
Yes, ma'am. Or while outstretching the hand, like those.
Yeah, same thing I want to ask. Like when he, if you have she or he had tremulousness only on the fingers, then it will be difficulty to while turning the paper or holding a spoon. But holding a water glass and taking it to mouth, that means it is more of proximal things, larger
Okay, sir.
joints. It should be some amount of elbow and wrist might be there. Otherwise, it won't have the tremulousness. No? See, taking water in a glass, you take it and take to your mouth. If there is a
Yes,
tremors that has to be a larger joint. If it is
yes,
smaller
sir. I
joints,
understood.
it would be more evident when you are taking a spoon or turning a paper, picking something on the floor. At that time, it will be using the small fingers.
Okay, sir. Okay, sir.
So it has to be there. I think it has to be there in the proximal also. And what
Mm.
happens? What happens when you go to the mouth? Whether it increase,
It is
decrease.
not increasing, sir. It is the same intensity all throughout the activity.
Any
And what
activity, he is getting this. At rest, it is not there.
Sir?
At rest, it is not there, and any activity he does the left hand, it is there.
Yes, sir. Yes, sir.
Okay.
so
It is
actually
not
at this
present at
point,
rest.
yeah. So you have to differentiate between this tremulousness. We want to go towards the myoclonus side or towards the tremor side. Okay, or
It
whether
is
this is a
not in
dystonic or
jerky nature,
tremor.
ma'am. It
Uh,
is not in
Actually,
jerky nature.
jerky thing will come in examination. That is what I'm trying to ask you. See, when you are
Okay.
describing this tremulousness, while that he is holding an object, we have to describe what are the changes with the anxiety or the stress, whether there any worsening while there's a loud noise or this thing, or
Okay, ma'am.
whether. Okay, so you have to differentiate at the same point. Otherwise, I
Okay,
mean,
ma'am.
this goes to be a wider in that term, so won't be
Okay,
good
ma'am.
useful. Okay. Yeah.
Yeah. When you think of a tremulousness as a phenomena, it can be myoclonus, it can be dystonia related tremors, or even a normal tremors. So all these things you have to differentiate. So what was happening? It was like more of finger plus proximal. It is only on not on rest, only on action.
Yes, sir.
So
Only while
why
action.
if myoclonus was there, you're telling about the fingers only. So if it is fingers, it was there, and if in extraabdominal syndrome, if it is fingers is there and upon action is there, then like madam was asking, you want to ask whether it is on sound, what happens? Then you want to think of what?
Myoclonus.
From where? Spinal.
Cortical myoclonus, sir.
So then you think of which disease? More likely.
CBD.
CBD. That is why it is very important.
Okay, sir. Okay, sir.
This etiological diagnosis also will help.
Okay, sir.
So you want to think this is what?
No, sir. Tremulousness only. There is no worsening or occurrence of the movement while loud voices.
Okay, so you want to think of what? Whether it is myoclonus, dystonia, tremors.
Tremors, sir.
Okay. So you want to tell it is more of an postural bar action tremor.
Yes, sir.
Okay. Then where it might be originating from? See, what is the difference when you are getting a rest tremor? In this case, you think of it is originating from.
Basal ganglia and its circuits, sir.
If there is a action tremor or postural tremor,
From the dentatorubrothalamus
any
cortical circuits.
cerebellar outflow or cerebellar connection
Yes,
that it
sir.
involved.
Okay.
So if an extrapyramidal, you're thinking of a postural and action with cerebellar involvement, which disorder you want to think?
MSA with the cerebellar type or PSP with the cerebellar
Yeah, any
variants.
MSA, the thing is that whether it is P or C, ultimately they will overlapping manifestations.
Okay, sir. Okay.
So there may be a cerebellar involvement, one possibility. Second is it can be even a dystonia. Or you can still keep a possibility of myoclonus because at one examination it may be something else.
Okay, sir.
Anything to add, ma'am?
No, sir. Continue. Yes, sir.
Complaining of giddiness from 1 year while getting up from the lying down position or while getting
One
up
second.
from the sitting.
Yeah, I just want to ask one more thing. This, like, suppose somebody is telling you that he had a tremor, and upon movement the tremor decreases, but still it is present. Okay, it is
Yes,
there
sir.
at the rest. It is there at the rest. It is there at the action. It is there at the posture. So, how to differentiate between whether it is from the basal ganglia or the IPD related rest tremors, or whether it is ET? Because when you have the ET patient, somebody has typed ET. That is why I asked. Many patients with the ET at later stages, you may see at the rest also they have some tremors.
Yes, sir.
Because even the rest, it is a posture. And the keeping the hand in a rest position, that is also a posture. So they can get tremors in the rest. So how do you differentiate? You do the finger nose, or when they start moving, if it is ET related, it will increases, or it is cerebral outflow, it increases. The tremor is very dominant on action or extending the hand. But in a dopamine insufficiency, whenever they start moving, the tremor decreases.
Yes, sir.
Okay. Okay,
Complaining
proceed.
of complaining of giddiness from 1 year while getting up from the lying down position or from the sitting position. No history of associated sweating or chest pain or shortness of breath. Not associated with any fall. No history of any swaying while walking. Complaining of bladder disturbances from 1 year in the form of urgency, urge incontinence, poor stream, feeling of incomplete voiding. Increased frequency at daytime, he is passing 5 to 6 times, at night time 2 to 3 times. Coming to bowel, he is complaining of incomplete evacuation and incontinence. Complaining of erectile dysfunction from 3 months.
We'll start one symptom. What about giddiness? Whether it is giddiness is a very non-specific entity. So what else you want to ask there?
Mm. He is particularly telling from getting up from the lying down position, sir.
Mm. What he feels,
Posture
whether it is blackout, whether it is feeling of rotatory vertigo, or whether it
means
is
not
feeling of
no history of spinning like sensation of himself or surroundings, sir. Only giddiness.
giddiness is very non-specific. Giddiness is like when you cannot tell what it is, you can tell it as giddiness. So whether it is the symptoms can be either they can feel like a lightheadedness, where they feel pre-syncope like symptoms like lightheadedness. Second is a possibility is they feel the entire thing is rotating. Third is a possibility that they feel the things are slightly moving. Sometimes in chronic, long-standing peripheral vertigos and all, they will just feel that the surrounding is just moving like oscillopsia. So if you are getting that, you can put it as exactly what is happening. So you definitely have to ask that whether there is any lightheadedness, whether there is any blackout, whether there is any true vertigo. Because on getting up from lying from supine can be a peripheral vertigo. They also, that also the patient will tell us for the patient everything is giddiness or dizziness. It will be difficult
Uh,
for the patient.
Not associated with any spinning like sensations or nausea, vomiting, or any ear difficulties, like hard of hearing or a ringing
Whether
sensation in
whether
the
there
ear.
is whether there is any blackout, syncope, or pre-syncopal episodes.
Blackouts he is not telling, sir. While when he feels the giddiness, he stops walking and he tries to sit down or lie down.
Okay. So whenever you get some symptoms like dizziness or giddiness, for the patient everything will be same. So you have to differentiate what it is. Sometimes you will not be able to differentiate. Then you can keep it as non-specific terms like giddiness and all. But if you are able to specifically tell it is lightheadedness or pre-syncopal episode, keep it like that only.
Okay, sir.
Or if you're able to get it as pure rotatory, you can keep it like that. If you feel like it is oscillopsia like thing, you can keep it like that. So that it will give more specificity to the history.
Okay.
Ma'am, anything
So
to add,
while
ma'am?
giving actually, yeah, so while giving the history of regarding this orthostatic drop that you want to say, so be specific to the word of a dizziness while standing, or it is a lightheadedness. One thing. Second thing,
Okay,
at the
ma'am.
same time, you have to say that there is no any vomiting like thing or any
Okay,
ear
ma'am.
discharge, and all those things which should also be differentiated at the same time, or peripheral
Okay,
causes
ma'am.
of
Okay,
vertigo.
ma'am.
Okay, and along with that,
Okay.
say regarding a palpitation as well.
Ma'am,
So
unable to.
yeah, and any preceding palpitation is there, or the patient is having any feeling of blackout, or something is black in front of his eyes. So that kind of history should also be given.
Okay, ma'am.
Okay, and sweating and chest pain, shortness of breath is fine. So that all the vertigo history and all the sense of rotation of surroundings was there or not. Any at the same time whether he was feeling any nausea or not. So those hearing problem is there or not. So those same time you have to tell about that these things were not there, and the patient that he is
Okay, ma'am.
trying to
Okay.
imply is actually at this orthostatic drop.
Okay, ma'am. Okay, ma'am.
Okay, because for patient everything is giddiness.
Yes,
Okay,
ma'am.
okay. Next, please analyze next symptom.
Bladder disturbances from 1 year in the form of urgency, urge incontinence, poor stream, feeling of incomplete voiding.
So what
What do you
is
think
it?
it is?
Uh,
First take
Both
urgency. Urgency. First we
urgency
take
is
urgency. Each are
UMN
different
complaint.
symptoms. Yeah. Urgency is
UMN complaints, sir. Urgency and urge incontinence.
okay. Then what all things comes in the human component of bladder symptoms? Hello?
Yes, sir.
Yeah,
From
other than urgency, what all things comes?
sir localization, sir, or
Human symptoms and element symptoms
other
of bladder.
associated.
Hello?
Yes, sir.
Yeah. What are the human symptoms of bladder? What are the element symptoms of bladder?
Urgency, urge incontinence.
Mm.
In element, dribbling, continuous
Frequency also.
dribbling.
Frequency
Sir,
basically,
increased
base,
frequency.
yeah, basically, human will have a problem about storage.
Yes, sir.
Element will have a problem about voiding.
Void.
So hesitancy, all those things are feature of element. Well,
Yes.
storage producing urgency, increased frequency, urgent continence, all these are features of human.
Yes, sir.
And what about the stream?
Port stream.
Yeah, stream, what happens in human and element? Human usually stream will be
In UMN, poor, sir. In element,
human stream can be normal. In element streams are usually can be
okay.
affected. But usually when you see a poor stream, you have an expression in male, you have to consider possibility of local causes like prostate also.
Prostate.
Especially if there is a hesitancy with poor stream.
Yes, sir.
Human usually
And
the
how
stream
do
is
you
normal.
how do you take a history of poor stream in male?
Uh,
What do you ask?
What he is telling is previously never his foot is used to wet. Now while passing the urine, they are falling over the feet or clothes.
Yes, and along with that, you have to ask whether there is any intermittent stoppage. For example, they pass the urine, then they have to again stream, then they will pass some urine, then they will again stream. So that
Okay.
intermittent disturbances in the stream will also be there.
Okay.
Okay, so hesitancy, poor stream or the thinning of a stream, intermittent stoppage while passing the urine, along with that, feeling of incomplete evacuation. So that is a history of your voiding symptoms.
Okay.
Nocturia, frequency, urgency, urge incontinence. Those are storage symptoms. Okay.
Yeah. Okay.
And why do this patient develop these bladder complaints in MSA?
Due to involvement of both intermediolateral cell column and one of nucleus.
Yes.
Ma'am?
Yes, correct. And what is the
Okay.
earliest symptom that these patients start developing?
Erectile dysfunctions, penile. Regarding bladder,
Among bladder, yeah.
earliest I
It's
don't.
nocturia. It's
Okay.
nocturia.
Okay.
The earliest, it's already in the process of aging. So in older age, people start getting this nocturnal complaints. And in MSA, as we are getting this degeneration of this autonomic system, so the earliest to develop is the multiple time they have to go in night.
Okay, ma'am.
Okay. Anything else, sir?
Nothing. Just whenever you're taking the bladder history, think of the pre-void phase, voiding phase, and post-voiding phase. Ask
Okay.
what all things you or the patient is going to experience. Pre-void
Okay.
phase, whether they have the sensation, and if they have sensation,
Okay. Able to perceive the
whether they
bladder
can hold
fullness.
it, then how much the frequency. Yeah, I'm
Frequency
just
is
telling you when you are
increases.
assessing the bladder, all these
Okay,
three
sir.
things should be asked.
Okay, sir. Okay, sir.
Yeah, first you ask about the periodic phase questions, then you ask about voiding phase. How
Then
is the about to initiate? How is the initiation? How is the stream? Whether he's able to
stream.
hold it. And more
Okay, sir.
important, like Madam was telling, how is in between the stream? Classically in prostate and LUS, lower urinary tract, you will have this breakage of stream, and whether it is dysuria is there, and whether it is hematuria is there. Then post-voidal phase, whether there is a dribbling, whether there is incomplete voiding, whether there is double voiding, and whether there is a hematuria happening post-voidally. Even hematuria are not likely to be neurological, but those things has to be covered. So
Double
voiding, pre-void,
voiding, sir.
voiding means he voids little bit, then he is not completely voided, then he will wait again or he will give a pressure to the bladder and he will void later also.
Okay. Okay. Okay, sir.
Okay. And incomplete bowel evacuation, how old is he?
52, sir.
Okay, diabetic.
No, sir. No comorbs.
Okay. What about the
No
erectile dysfunction?
comorbidities, sir.
Erectile dysfunction, all usually in this MSS and all this autonomic dysfunction usually happens very early. Very
But
early,
he is
usually.
giving from 3 months
Yeah.
only, sir. Well,
Okay. So there was no change in the abnormal sweating or increase or decrease sweating, nothing.
no, sir.
Okay.
And what other autonomic history you will take?
Postprandial dizziness.
And postprandial fullness as well.
What, ma'am? Postprandial?
Postprandial fullness as well. Abdominal symptoms.
Fullness. Okay. Okay, ma'am.
Yeah.
Okay. Can I move, ma'am, to the
Yeah,
next
please
slide?
continue. Please continue.
Able to perceive smell normally, visualize and scan the surroundings normally. No history of drooping of eyelids or double vision. Able to perceive sensations over the face and chew the food normally. No history of deviation of angle of mouth or drooling, increased drooling of saliva or burning sensation in the eyes while washing face. No history of any hard of hearing or ringing sensation in the ears. Complaining of choking episodes from 5 months, both to solids and liquids. No history of any nasal regurgitation. No history of difficulty in swallowing to solids and liquids. Able to shrug his shoulders and turn the head sideways and bend forward normally. Able to manipulate the food within the mouth and clear the food particles. Shall I continue, sir?
Yeah, there was, is there, you were telling, yeah, you were telling that he had hoarseness. What about stridor or anything else? And choking is
Yes.
already there for solids and liquids.
Yes, sir, for both solids and liquids.
Okay.
Wife noted that in the sleep, noisy breathing at night time while sleeping, as if patient is struggling to get the air. It is present from 1 year onwards,
Okay.
associated with increased excessive daytime sleepiness. At this point of time, they consulted the doctor, and after the sleep study, they advised the BiPAP. With the BiPAP, this noisy breathing at night time and struggling to get air is subsided, is telling, and excessive daytime sleepiness also decreased.
So actually, again, this is Anna. The patient never tells that they are having a feeling, or the attendant don't complain this thing that they are having a feeling that patient is struggling. They just sits at either a noisy breathing or he has started taking more snoring.
I
So
asked how it appears. So then she
yes,
told
yes.
as if
Yeah, so the history actually that we get in a patient is the commonly is that they are having either a noisy breathing or a more snoring, and that because of that he sometimes wake up from the sleep, or this is disturbed, and along with that they do have an increased daytime somnolence. That is the
okay,
history. I mean, this kind of history seems to be like that. We know the case, so
so okay,
that
so
yeah, so that should not be told while giving exam.
okay, okay, okay.
Yeah. Anything else, sir?
After starting the BiPAP, sleep onset is normal. Falls asleep immediately. If wakes up in the middle of the night, goes to sleep by 10 p.m. From 10 months onwards, attendant noted she's telling roughly exact time. At the time she don't know, roughly it is about 1 a.m. Then the patient shouts that buffaloes are coming to the field, make them to go out of the field, like he tells shh, shh, make them get out of the field, like that. If the partner asks what happened, the partner wakes him up and asks what happened. Then he sees the surrounding and tells, okay, it's dream. No history of excessive daytime sleepiness from then onwards. Appetite is normal. No history suggestive of any cognitive disturbances. No history of any excessive laughing or crying or inappropriately. No history of any visual hallucination.
Okay, what do you think the
Any
symptom is?
REM sleep behavior disorder.
What time it happened? From
Exact
name.
time she is not telling.
Okay.
About he goes to sleep by 10 p.m. at around 1 a.m. like that.
Okay. Whether I mean, stood up in the bed or he enacted it or something like that.
He's sitting over the bed and he's telling ush and putting the hands to like as if he is trying to move them away from the field.
Okay. There was a motor movement also there.
Yes, sir.
Only once or multiple times?
Multiple times, sir, from 10 months onwards.
Okay. So RBD
But
also usually
mostly
present
at
very early.
same type of episodes they are telling, sir. Like buffaloes coming to the field. It's the same thing.
REM was there in since last 10 months.
Yes, sir.
And he remembers the event?
He's when she wakes up, he remembers that, sir.
Remembers that.
Yes, yes, sir.
He remembers what happened the night. Usually it is not seen. REM usually they won't remember.
Uh, when the
REM he
middle
will
of
remember.
the night, when the wife asks, he tells, okay.
Okay. Okay.
and, yeah, one more thing. Can you describe the underlying pathophysiology of REM sleep behavioral disorder in this patient?
Okay, ma'am. Normally in REM sleep, the muscle tone is decreased because from the sub, sublateral dorsal nucleus of pons. From there will be direct and indirect path. From the direct path, it directly inhibits the spinal motor neurons. From the indirect, it goes to the medullary reticular formation tract. From there, it inhibits the extensors. Hello,
Okay,
ma'am.
and what happens in these patients?
In this patient, due to degeneration of that nucleus, there is a inhibition of the muscle tone inhibitors. Therefore, it is increased tone.
Okay, so basically, what happens at the time of a sleep, there is this pons and this midbrain switch is there. So, which convert it from NREM and REM sleep. Okay, so whenever you are going into REM sleep or REM sleep, there are two things. One thing goes to the cortex, and another thing that goes to your spinal cord. So,
Spinal cord.
whenever you are dreaming, or the cortical activity is going on at the same time, this REM sleep switch it switch off your muscle activity. So when that pontine nucleus is disturbed, so there is the cortical activity is going on, but because of that disturbance, now you are unable to inhibit a motor movement. Okay, so
Okay.
that's how the person is dreaming, and all the dreams are now going to the act out. Okay,
Okay, ma'am.
how will you differentiate this RBD from your frontal seizures? Yeah, hello, Deepti, Dr. Deepti.
Yes, ma'am. Yes, ma'am.
Yeah,
Yes, ma'am.
yeah.
Yes, ma'am.
So, I mean, how will you differentiate whether you are dealing with REM sleep behavioral disorder or frontal seizures?
Mm, no idea.
Oh, it's a simple
Not.
thing. In the frontal seizures, the seizure is what? It's a hypersynchronous activity, and it will have a same morphology or the same semiology the patient will be having every time. Okay, while in
Okay,
REM
ma'am.
sleep behavioral disorder, it will be different every time. It's not going to be the same. So the seizure has a classical
Okay.
semiology, or the every time the patient will have a classical semiology. And while these patients, they won't be having, and especially the frontal motor seizure, they are very hypermotor, very violent.
Yes,
They'll
ma'am.
shout and they will just run and they will just make a lot of noise. Well, in REM sleep behavioral disorder, sometimes they can make, sometimes it will just be motor movement, or some just there's some like some night talking like thing. So that's how we have
Okay.
to differentiate. And the frontal seizures are mostly in the early part of a sleep. Well, REM sleep
Okay.
is when the first phase of an REM is longer. Then you switch on to the REM sleep. So that will be almost in the mid of the night, or you can say 2 3 hours after sleep. Okay.
Okay.
Also,
Okay.
the seizures are
Yes.
very short, brief duration. REM sleep usually lasts for long duration, and usually
Okay.
single episode REM sleep. The other one can be multiple episodes also, and more
Okay, sir.
frequency in the case of frontal lobe.
Okay, sir.
And other than visual hallucinations, we have to take history of delusions as well. In
Okay, ma'am.
cognitive disturbances, take history of delusion as well. Okay.
Okay.
Okay. Continue.
Coming to past history, no history of any coronary artery disease or cerebrovascular accidents, not a diabetic or hypertensive. No history suggestive of any thyroid disorder. Coming to personal history, he takes mixed diet, occasional alcohol intake during functions mainly, not a smoker. Coming to personal history, born out of non-consanguineous parentage, fifth in birth order. His elder brother having tremulousness and slowness of activities of daily living. Onset at around age of 40 years. Now he is 70 years old, ma'am. He is on levodopa. With the treatment, there is improvement, is telling his brother. The other sibling is also younger sibling having tremulousness, but he is not on any treatment. They are unable to give exact semiology because they are not in contact. He is telling. Coming to drug history, he is on levodopa with carbidopa 125 thrice daily, midodrine 2.5 mg thrice daily, pantop 40 mg once daily, oxybutynine 5 mg thrice daily. Summary.
Yes, please go.
52 years old male, not a hypertensive or diabetic, with hoarseness of the voice and dysarthria from 2.5 years, slowness of the activities related to left upper limb and lower limb from 2 years, along with the stiffness. While walking, trunk is bent towards right side. Postural and action tremor of the left upper limb. Autonomic disturbances in the form of postural giddiness, double incontinence, erectile dysfunction, inspiratory stridor, REM sleep disorder without an involvement of any cognition, motor, sensory.
Okay, so what are the differential diagnoses?
Longer duration, so most probably degenerative.
Okay. And what are the cases where do you get this rapidly progressive illnesses? Till what duration? You will go for evaluation of these treatable disorders?
1 year, 6 months to 1 year.
Yes. And more than that, it's usually the degenerative.
Okay. Yes, ma'am.
Yeah, any why this hoarseness happens?
As I am in hoarseness of the voice,
Hello,
both are present.
hello, not audible.
Sir,
You are not audible.
sir,
It is
now,
because of it is because of not because of nerve involved. It is because of dystonia.
hello, sir.
It is basically because of dystonias of the
Okay, sir.
and laryngeal muscles
Due
and strider.
to
Everything is
the
because of that.
abduct. Yes.
So if you want to consider something treatable, if the duration is supposed to be less, what else you want to evaluate?
Hello,
Brainstem encephalitis.
anything can present with REM sleep disorders,
Hello, sir.
slider, anything, any other diseases can
Audible.
treatable which can present with REM sleep disorders and all.
Glon-
Iglon 5. Iglon 5, whether it is, I mean, whether it is degenerative or whether it is
uh,
autoimmune.
Iglon-
Both pathologies are there.
Initially, it is not. Later, it becomes degenerative. Yes.
It has some response to
Yes, sir.
immunotherapy. So both pathologies are there, degenerative and autoimmune. Am I audible? Hello?
Yes, sir. You are
Yes.
audible, sir. Yes,
Sound
sir.
is
You are
getting break.
audible, sir.
Okay. So what all things in this history, what make you think of it is atypical Parkinsonism first, and second, what made you think of MSA? Or how will you classify Parkinsonism?
Okay, sir. Uh, Early involvement of economic disturbances.
It started with hoarseness of voice. That is
Parkinson's is
basically
referred to idiopathic, uh, atypical.
Dr. Deepthi, your voice is not clear. Your voice is breaking too much.
Audible, sir.
I thought it was my network problem. Okay.
Yeah, you are not audible, Dr. Deepthi. Sir, am I audible?
Yeah, ma'am, you're audible. I think her network issue.
Maybe, sir.
Sir, am I audible? Hello, sir.
Yeah, now audible.
Okay, sir. Sir, now am I audible, sir?
Yes, yeah. Now you are audible. Please continue, Dr. Deepti. Again, not audible.
Parkinsonism is classified into idiopathic. No. Hello, ma'am.
Yeah, now it is clear.
Parkinsonism disease can be classified into idiopathic, atypical, Parkinsonism plus multi-system involvement, secondary Parkinsonism. Hello. Hello, ma'am.
Yeah, yeah, Dr. Deepti, please tell.
Idiopathic Parkinsonism can be sporadic or hereditary. In multi-system degeneration, it is PSP, MSAP, MSSE, CBD.
It's basically divided into idiopathic Parkinsonism, atypical or Parkinsonism plus syndrome, then secondary Parkinsonism, and heterodegenerative Parkinsonism.
Yes, sir.
So atypical or Parkinsonism plus has all these MSA, PSP, and all.
Yes,
Then,
sir.
then you
Heterodegenerative.
then you have heterogeneration secondary. Secondary has your drug induced in PH. Then some of the vascular Parkinsonism, all those comes in secondary. I mean, certain toxin induced, all those things. Post encephalitic Parkinsonism, all these are secondary Parkinsonisms.
Okay, sir.
Heterogeneity have all these genetic Parkinsonisms, Lubag and all those
Huntington's, Wilson's,
Huntington's.
NBA.
Then mineral deposition disorders, all those things comes there. So
Okay, sir.
in this case, there is early history of hoarseness. Then it is what all things are red flag signs in
Autonomic
Parkinson's?
disturbances.
Red flag
Red
signs.
flags, hoarseness of the voice, autonomic disturbances, inspiratory stridor.
Okay.
Hello, sir.
Yeah, and not in this case. In general,
Hello, sir.
in general, what all things you will consider?
In general, early involvement of co- cognitive, early involvement of cognitive disturbances, early falls, wheelchair bound, autonomic disturbances, apraxias, cortical sensory deficit, alien hand phenomena, bulbar dysfunction, inspiratory stridors, apneic spells.
Okay.
Sim.
And persistent asymmetry.
Yes, ma'am. Symmetrical is red flag. Okay, yes, ma'am. Shall I move forward, ma'am?
Yeah.
Hoarseness of the voice and nucleus ambiguous motor, brainstem involvement. For the slowness of the activities related to left upper limb and lower limb, nigrostriatal path on right side. While walking, trunk is bent toward right side due to dystonia. Action tremor that is present in during postural and action might be due to dendrothalamic cortical cerebellar connections. Autonomic disturbances due to involvement of intermediolateral cell column and one of nucleus. Inspiratory stridor due to laryngeal muscles dystonia. REM sleep behavior disorder, sublateral dorsal pontine nuclei. That's it. Localization. Diagnosis, DDs or MSA. Shall I move forward, ma'am? Examination.
MSc which type?
As it is gross asymmetry Parkinson's, MSAP.
Okay. Go forward to the exam.
On general examination, well built and nourished. No pallor, no ectasis, no cyanosis, no clubbing, no lymphadenopathy. Pedal edema, blink rate is decreased. It is 8 per minute. Coming to vital data, his febrile, blood pressure 130 by 90 in supine. After 3 minutes of standing, 100 by 70, pulse rate 86 per minute. Coming to specific autonomic function test, blood pressure in supine, it is 130 by 90. After standing for 3 minutes, it's 100 by 70. Pulse rate in supine position, it is 86 per minute. Immediately after standing, it is 90. At 15 seconds, it is 92. At 30 seconds, it is 88. The ratio is 88 by 92, which is equal to 0.95, less than 1.01. Coming to heart rate, compare while doing deep breaths, he had to take 6 breaths per minute. 10 seconds, one inspiration and one expiration. During that time, he should be connected to the ECG. At that time, we should take 5 cycles of this. During expiration and inspiration, minimum heart rate by maximum heart rate. During expiration, we take minimum heart rate. During inspiration, maximum heart rate. His minimum is 86, but my maximum is 90. The ratio is 0.95. Normally, it should be more than 1.01. Hand grip,
It's not
we
heart
should
rate.
ask the.
It's not heart rate, it's RR interval. So while you are checking for deep breathing, you have to check the RR interval in the all the inspiration and all the expiration. So all that has to be combined. The RR, the just longest RR interval of expiration and to the shortest RR interval of inspiration. So those all 5 breaths has to be combined and then to calculate the ratio. And that is more than age of the 65 to 75.
Average,
Yes. What?
ma'am, isn't it average we have to take?
No, no. It's all the six. All the six you have to
Average,
calculate.
average of the 5. Okay,
No,
okay, ma'am.
you see, you will take RR interval for the whole minute. Okay.
Okay,
You will be doing a continuously ECG monitoring for the whole minute. 5 second inspiration, 5 second expiration. So total 6 breath cycle will be there, 6 breathing. Okay.
yes,
And
ma'am.
in that
Yes, ma'am.
expiration, you will mark it. And when your ECG is going on, you will mark whether it is an
Yes, ma'am.
expiration part or the inspiration part. In that
Okay, ma'am.
expiration, you will take the longest RR for E1,
Okay,
E2,
ma'am.
E3, E4, E5, E6. Okay. And
Okay,
for inspiration, again, you will again check I1, I2, I3, I4, I5, I6. That
okay,
ratio
ma'am.
to be
Okay,
calculated. And it should be more than 1.04 and more than 1.07. So 1.04 for more than 75 and less than 65 to 75 is more than 1.07. So that is the method to check it. Okay.
actually,
Yes.
I
Again,
taken
yes.
RR
Go to the next
interval
slide.
only, ma'am. Hello, ma'am.
It's okay. This was RR interval.
RR interval only, because RR interval we consider as heart rate, na, ma'am. That's why I put like this.
No, just tell it
But
as a
I
RR interval.
taken the
Don't say.
average of
No.
that 6 breaths,
Okay.
ma'am.
So
Average.
just write it as an RR interval, not the heart rate. Okay.
Okay, 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 ma'am.
Okay.
Hand grip, I asked the patient to make the fist. Before and after I checked. Before is 130 by 90. After 3 minutes, it is 135 90. Diastole should be increased normally by at least 10 mm. But there is no increase in this patient.
So again in hand grip, it has to be done with hand grip dynamometer. So in that
Not,
you do with the time. I get it. So actually, ideally it should be done with dynamometer. You will check the
okay, ma'am.
maximum
Okay, ma'am.
hand grip strength of a patient. So in that maximum hand grip, you will go for a 60 to 70% of that hand grip that has to be sustained.
Okay, 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 ma'am.
So okay, during the hand grip and before that. So that
Okay, ma'am. Okay, ma'am.
change has to be seen. It's not just a
Okay,
normal
ma'am.
hand grip. Person might not be or just voluntary and he won't be making that much hand grip. So then test will get a fallacious.
Okay, okay, ma'am. Valsalva maneuver I am unable to do, ma'am, because manometer is not available. So,
Okay, can you tell the
hello, ma'am.
method of Valsalva? Yeah, hi. Can you tell the method
Yes,
of how
ma'am.
do you
We
do it?
should keep a mouthpiece to the patient, and we ask to after we should block the nose, ma'am, with the clip, and then we should keep a mouthpiece, and we ask to blow uh, into the mouthpiece. The pressure should be 40 mm. Hello,
Okay.
ma'am.
Yeah. Okay.
Then we will take the while while he's blowing, we will take the ECG, and after relaxing, how I don't know how to tell them, but after finishing the blow, again we will see the ECG.
Okay. So again, the ECG monitoring has to be done continuously while you are doing
Continuous.
the
Yes.
Valsalva. So there are 4 phases. Okay.
I
And
think.
how will you do connect the mouthpiece with what thing?
Ma'am?
How do you connect the mouthpiece with manometer?
That I don't know.
Okay. So basically, what do? You take a syringe and remove its plunger. And
Okay. Okay,
inside
ma'am.
the part of the syringe, you just connect it. You just remove the half of the BP part, that is the tube that connect from the BP, this cuff to the tube. You just disconnect it, and
Yes, ma'am.
at that
Yes,
point, you
ma'am.
just insert that. Just connect that your
Okay.
the
Okay.
syringe, and then you ask a person to blow into that. One thing first, you have to train the person. You can't put a clip on that a patient. No? It's not. Patient won't be comfortable, and he won't be as cooperative while doing the test.
Okay.
So
Okay,
first you
ma'am.
have to just explain them that you just have to pinch your nose or how to do that Valsalva, and then you will ask them to blow inside that
Okay.
syringe. Okay, and you have to
Okay.
tell them that it should be this much forceful that your manometer should rise to 40 to 50
Okay,
mmHg.
ma'am.
Okay,
Yes,
and
ma'am.
then you will note down the phase 1, 2, 3, and 4.
Yes, ma'am.
Okay, okay, go ahead.
Delayed
Anything
pupillary
else, sir?
constriction.
Anything
Nothing,
else, sir?
nothing. Nothing, nothing. Only thing is that in exams you will be able to do only supine BP and the pupil reflex. Meaning even exam time it is difficult to do. So
Yes,
you should
yes,
know
sir.
how to do it. That's all.
Okay, sir. Coming to mini mental status examination, he is illiterate. He scored 20 out of 30. He'll ask for orientation to date, month, and year, and he'll ask for orientation in place, state, and country. He lost. Registration is present. Simple calculation 20 minus 3 he is able to do. In recall, it with cues. Without cues, he is able to recall one, but with even with cues, he is unable to recall rest of the two. On repetition he is able to do. Object naming 3-step command he is able to do. As he is illiterate, writing a sentence and writing a command he is unable to do. Copying the diagram also, it's wrong. He is unable to do. Coming to lobar function test, attention digit repetition forward 6, backward is 3, sustained attention is intact. Similarities he is able to tell 3 out of 3. Differences he is able to tell, fund of information is present. Proverb interpretation is intact. Coming to verbal fluency, categorical animals he is able to name 10, vegetables 12, lexical fluency 8. Visual pattern completion test, I asked to complete my diagram, ma'am, sir, but he told I can't do like that, but I will copy the diagram, and he did in this way. Motor luria unable to do. Go no go test is normal. Coming to temporal lobe, digit repetition forward is 6, backward is 3, sustained attention is present, recent memory is intact, remote marriage days, birthday, schooling, these all he is able to tell now. Paired associate learning, 4 unrelated words, immediately he is able to tell. Verbal story, able to tell the whole story correctly. Visual memory, 5 out of 5. Coming to parietal, praxis normal, finger naming correct, right and left orientation is intact, calculation only simple, complex he is unable to do, construction not able to do, no dressing apraxia, geographical orientation is intact, cortical sensations are normal. Occipital lobe, visual fields are normal, color vision is intact, recognition of faces intact, object naming normal, no visual agnosia, no simultagnosia.
Okay, so how will you differentiate this Visual agnosia from the optic aphasia and from this anomia.
Ma'am, visual agnosia, the other things are what, ma'am? I can't
Optic
hear.
aphasia
Optic aphasia. Yes, ma'am.
and then anomia. Specifically, optic aphasia from anomia.
Mm.
What is optic aphasia?
In in optic anomia, he is unable to tell the name of it when he sees, but when we give the same object in the other modality of sensation like tactile or via auditory, he is able to tell that name.
Okay, good. And in the anomia?
In optic anomia, in whatever modality we give, he is unable to name, ma'am, but he is able to tell the function of the object.
Okay. And how do you check for geographical orientation? How did you check?
I asked how did he came to the hospital, and I asked how to if I want to come to his house, how I have to reach the his house. He told his landmarks, all this. His son told it's correct only. The other thing
Okay.
I asked what the items are beside him in the class in the examination area.
Okay. Fine. Please go ahead.
Coming to cranial nerve examination, olfaction is intact. Optic nerve, visual fields, visual acuity, visual fields, color vision is normal. Fundus is also normal, ma'am. Ocular motor nerve 346, extraocular movements normal. Saccades are normal, pursuits are broken. Coming to trigeminal nerve examination, sensory motor
Gaze,
normal.
gaze,
Ma'am,
gaze, gaze, gaze. Horizontal gaze, vertical gaze.
pursuits are broken in both horizontal and vertical.
Gaze were normal, both for horizontal and vertical.
Normal, ma'am.
Okay. That has to be told specifically no?
Okay, ma'am.
In
Okay, ma'am.
case of extrapyramidal. All the
Okay.
six movement has to be told. Gaze, saccade, pursuit, vergence, VOR, and optokinetic nystagmus. Okay.
Okay. Okay, ma'am.
Okay. Please go.
Trigeminal nerve examination, sensory and motor are normal. Georgia present. Seventh cranial nerve examination normal. Air conduction is better than bone conduction. No lateralization. Coming to 9 and 10, uvula is center. Palatal movements are equal on saying up, but movement is reduced on both sides. Gag is intact now. Sternocleidomastoid and trapezius muscles power is normal. Tongue power bulk movements are normal. No atrophy. Coming to motor,
Just for once revision, can you just please tell me the method of olfaction testing?
uh, we should ask we should close one nostril, ma'am. First we have to close one nostril, and then we have to we should ask to close the eyes as well. Then we have to bring the substance nearer to the nose, and we ask him to take to inhale it, and we ask whether first he is able to perceive any smell or not. Second, if he is able to perceive, then what is the substance?
Okay. So that is the most common mistake actually we do while we tell in exam. The first thing you have to check is the patency of nostril.
Okay, ma'am. Okay.
Okay. How do you check it?
Uh, we should lift the nostril upwards, and we should look by placing the torch, and we have to see any.
Okay,
Oh,
so you have to do it by inspection by just doing a torch examination. Along with that,
okay.
you will keep a wisp of cotton in front of his nostril. Just close one nostril one by one and see whether with inspiration and expiration it moves or not. Okay.
Okay,
The
ma'am.
other way
Okay.
is you just take your spectacle or patient's spectacle and keep it in front of his nostril. And then you see whether the fumes are
Missed.
there or not,
Okay, ma'am.
or the mist is there or not. So
Okay.
that's how you first have to check the patency of nostril.
Okay, ma'am.
And after that, you will start the examination. And the fragrances or the smell that you are going to use, that should be familiar to the patient.
Okay, ma'am.
Okay. And then you will go for your testing. And correctly, the first you will ask that whether he is able to perceive or not, and then whether he is able to tell the name or not.
Okay.
Okay. Go ahead.
Coming to motor examination, tone is increased both in the left upper limb and lower limb. Rigidity, ma'am, involved both the flexor and extensor group of muscles. Power is normal in all group of muscles. Abdominal reflexes are absent. Plantars bilaterally flexor. Coming to deep tendon reflexes, it is 2 plus in biceps, supinated triceps. Knee is 3 plus, ankle 2 plus.
Did you check for this rigidity in right upper limb and lower limb as well?
Yes, ma'am, normal, ma'am, normal. So
And
I didn't
froments
mention, but
got also done. You checked for? Do you checked with froments as well?
with froments I didn't.
No, froments whenever. Did you do it in right upper limb or lower limb or not?
I did the had seen the tone, ma'am, in the right upper limb and lower limb as well. It is normal, but I didn't see with the froments
So it should be done in both the. I mean, if the left upper limb and lower limb is having clear cut rigidity, then it's fine. But in the right upper and lower limb, you have to check. If it is
Ma'am, that
not
means
there, then go with
if
the froment. Go with the
ma'am,
froments as well, whether you are getting any induced
okay.
rigidity or not. Okay. And along
Even
with
if
that,
it is
axial
normal,
rigidity.
we have to check with froments maneuver,
Yes,
ma'am.
you have to check it
Okay,
whether your patient is
okay, okay,
developing it
ma'am.
or not. Okay, whether
Okay,
it's complete, it's strictly asymmetrical, or it is just asymmetrical, more on the left than the right.
okay,
For
okay,
that
ma'am.
check. And along with the same time, you have to comment on axial rigidity also.
Mm. Yes, ma'am. Yes, ma'am.
Okay. Okay, go ahead.
Coming to extrapyramidal system examination, blink rate 8 per minute, tremulousness of left upper limb involving fingers, postural while outstretching his hands and while moving while doing finger nose test, but there is no increased tremulousness on reaching the nose. Bradykinesia is present in both left upper limb and lower limb, not seen in right upper limb and lower limb. Rigidity is noted in both left upper limb and lower limb. Full test is negative. Meyerson's sign is positive. Palmomental is bilaterally present. Snout pout is absent. Grasp reflex is absent. Applause sign is also absent.
Okay. Did you do the Archimedes spiral?
No, ma'am, I didn't.
That must be done. What happens to Archimedes spiral in Parkinson's, and what happens in essential tremor?
In Parkinson's, it is all throughout the spiral, it is wavy, ma'am. And
Okay.
the spirals will be more and more nearer compared to the ET, essential tremor. Essential tremor, the spirals will be more farther and more wavier.
Okay. So it's an axis or the 10 to 2 position that we say. So in case of Parkinson, it will be having a tremor in all the movement, or initially if there's just rest tremor, might not be there. While in case of essential tremor, you will be having a tremor and then you will get some excess. For example, at some part they will be normal, at some part they will just make an excess and again they will start make a tremor. So that is the thing, that how will you differentiate Archimedes, this essential from the Parkinson in Archimedes spiral.
Okay.
Sir, anything else to add, sir? Sir? Okay. Go ahead, Dr. Deepthi, please.
Coming to gait, trunk is bent towards right, base is narrow, two-foot posture, arm swing is reduced on left side, step length and height is reduced. While taking the turn, he is taking 2 to 3 steps to complete the turn. Shall I show the video, ma'am?
Okay. So, yeah, please show the video. Okay, so can you describe him?
While walking, the trunk is tilted towards the right side. The base is narrow, and the arm swing is reduced on left side.
And so actually, there is one mistake in this video. Can you please tell me? Not a mistake, actually, an incomplete thing.
Ma'am,
This video is incomplete. Can you tell me?
from sitting position, we have to
Yes.
start.
So the gait examination should be start from the person is standing from the sitting position. So what
Okay,
happens
ma'am.
in case of PSP? What happens in MSA? And what is there in IPD?
In PSP, when he is standing from the sitting position, there can be postural instability. Will be slightly wider, and the posture is retrocolis. Mm,
Okay. Can you name that sign? What we call it, and why does it happen?
retrocolis, ma'am.
No, no. What is the sign the person that PSP person when they stand from the sitting position or from the chair?
Okay.
Yeah.
Rocket
What it
sign.
is? Yes, rocket sign. So what happens whenever you are standing from a chair? So whenever a normal person stand, they first abduct their thigh. After that, they make a movement at their trunk and then they stand. Well, what happens in PSP? There is a loss of these postural reflexes. Okay, so the person
Yes,
just
ma'am.
try to stand without making any postural correction. So that is
Yes,
why
ma'am.
they're called as a rocket sign.
Okay.
Okay, and what happens in MSA?
In case of MSA, there is a slightly stupid posture from sitting to standing position. Base is narrow.
Base can be narrow,
Bases
can be
can
wider.
narrow and wider. If it is cerebellar,
Yeah,
it is wider. In case of
mostly it is
MSAP,
wider.
ma'am?
Mostly it is wider because
Uh,
instability is higher. So
yes,
it's
ma'am.
a
Yes,
natural
ma'am.
response. It's a natural
Yes, ma'am.
response to keep your base wide whenever you are feeling unstable. So it's mostly wider.
Yes, ma'am.
And again, more than that, they might have a syncope at that time also. If they're having a
Okay.
severe autonomic dysfunction or you are examining some late stage patient, if there's a significant orthostatic hypotension, they may feel lightheadedness
Yes,
during that
ma'am.
time.
Yes, ma'am.
Okay. Then next step, you have to make them a stand, simple standing before walking. And
Okay,
at the
ma'am.
same time, you will check for their base again. Any
Yes, ma'am.
instability or any swing they are having or not.
Yes, ma'am.
Any posturing is there. Okay. And
Okay, ma'am.
after that, you will make them walk.
Okay, ma'am.
Okay. So while walking, this person is having small steps. The stride
Yes,
length
ma'am.
is short.
Yes, ma'am.
And what happens in the stride length in MSSC?
Variable, ma'am. It is
Yeah.
variable.
Cerebellar. Yes, it's cerebellar ataxia. It is variable stride length. Okay.
Yes, ma'am.
And what happens in turning in MSA versus PSP or IPD versus PSP?
In case of PSP, there can be pivoting, ma'am.
What is that? What is pivot?
Basing on one step, he tries to uh, turn. Means the
So basically,
others.
he will just fix his one foot, and from the
Yes,
other
ma'am.
foot, he will just make a turn. That is what a pivot.
Yes,
Okay.
yes, ma'am.
And while in case of MSA or in case of IPD, there will be a multi-step turning.
Yes, ma'am.
Okay. And then you will check for pull test. And last, you will
Yes,
check for
ma'am.
pull test. Okay.
Yes, ma'am.
Can just for revision, can you tell me what are the types of freezing you can encounter in these patients?
Initiating while initiation freezing, turning
Mm-hmm.
freezing while turning,
Okay. Then
simultaneously while doing two tasks. I don't remember the name, ma'am. While doing the two tasks at a time, while walking and talking on phone like that.
okay. Next, when sudden obstacle comes.
as while crossing the narrow passage or while there is obstacles.
Okay. And finally, it's a terminal freezing.
Okay, ma'am. Okay.
Hello, am I audible?
Yes, ma'am.
Yeah, sorry, some network issue was there. I just lost connection. Was it with everyone?
I also lost, ma'am. Now I am opening
Okay.
again the slide.
Okay.
Coming to sensory examination, uh, pinprick temperature, joint position sense, and vibration are intact. Cortical sensations were also intact, ma'am. Cerebellar finger nose test, knee heel test normal, ma'am.
Okay. So before just
Can I
going on to the
summarize?
yeah, before going on MRI, just summarize the case.
Yes, ma'am. 52 years old male, not a hypertensive and diabetic, with the hoarseness of the voice and dysarthria from 2.5 years, with bradykinesia and rigidity of left upper limb and lower limb, uh, with PISA sign, action tremor of left upper limb, with autonomic disturbances, inspiratory stridor and REM sleep behavior disorder, along with choking episodes. One thing, without any cognitive involvement, motor and sensory
And cerebellar.
and cerebellar. Okay.
Hmm. So what is it?
MSAP.
So we will say it is a atypical Parkinsonism, probably
Okay.
MSC,
Okay.
MSA type.
Okay, ma'am. Okay.
Okay. Okay.
Okay.
Fine. Can you tell me the diagnostic criteria of MSA?
Uh, the first we have he had to have autonomic disturbances, ma'am. In autonomic disturbances, he can have postvoidal residue more than 100 ml or orthostatic hypotension with systolic blood pressure dropping less by 20 mm and diastolic dropping by 100. Sorry, 10
Right.
mm of
10.
Hg. Yes, ma'am. 10 mm of Hg.
It is for probable or possible.
Then it should have in atomic dysfunction, the patient should have this postvoidal residual or orthostatic hypotension or urge incontinence, any one associated with Parkinsonism features which are poorly responding to levodopa, cerebellar syndrome with at least two among them gait ataxia or limb ataxia, cerebellar dysarthria or oculomotor dysfunction. For probable core features should be at least two along with supportive, ma'am. Core features are
Yeah.
these autonomic and Parkinsonism or cerebellar.
And
Hello,
supportive
ma'am.
features? Yeah, supportive features.
Uh, like they are clinical, madam. Supportive like rapid progression within 3 years of motor onset, postural instability, craniocervical dystonia, severe speech impairment within 3 years of onset, dysphagia, unexplained Babinski, postural deformities,
Hello, hello. Am I audible? Am I audible?
There is some network issue from Dipti, I think.
Yeah. Dr. Deepti? Uh, Sir, should we continue or we should conclude over here only? Dr. Deepthi, am I
Yeah,
audible?
you can summarize, then we will conclude.
Okay.
You can give
So,
final summarization.
okay. So today we all discussed regarding the case of a extrapyramidal disorder, the hypokinetic one.
Please came back,
So,
I think.
sir, am I
Dr.
audible?
Dipti, yeah, you are audible. Dr. Dipti also came back.
Okay, sir. Okay.
Dr. Dipti, are you online? She has to unmute. She is still mute.
Once, sir, I will do it. Sir, I, sir, I unmuted, sir. Hello, sir.
Yes,
No,
yes,
Hello,
you
sir.
can.
now you are audible, sir. You are audible, Dr. Deepthi.
Okay, ma'am. Shall I repeat, ma'am? Hello,
No,
ma'am.
no, it's fine. It's fine. Yeah,
Okay,
it's fine, Dr. Deepthi. Please go ahead.
okay. Shall I go to the imaging, ma'am?
Yeah, please go to image.
These axial cuts, madam. Axial cuts, flare images. This, if we see when compared with the left side of the lentiform nucleus, the right side is atrophied and there is hyper intense in the lateral margin. Hello,
What
ma'am.
is that called? Yeah, what is that
Putaminal
called?
rim sign.
Yes,
Putaminal rim sign.
putamen ring. Okay. Other than that, what can we appreciate?
Uh, cerebellum atrophy or pons
So
atrophy, I
generally,
am unable.
if you see the Stephen fissures are also open.
Yes, ma'am.
Although
Yes,
should
ma'am.
be checked in T1 image, but they are comparatively for a 50-year patient, they are comparatively open. So there is cerebral atrophy as well.
Okay, ma'am.
Okay. Anything else on sagittal section?
No, ma'am. For we had taken for any bird, bird beak appearance sign, but there is nothing like that. No, no, just for
Okay. So
information sake.
just for revision, okay, just for revision, can you tell me what are the parts of a hummingbird, or what does this bird and what structure does it make?
Uh, Head of the bird is midbrain, ma'am. Body is pons. Wings are cerebellum.
And beak?
Beak is peduncles of the cerebellum.
No, beak
Sorry,
is optic chiasm.
midbrain. Hello, ma'am.
No, beak is optic chiasm. Optic chiasm.
Okay,
Anterior to
okay.
midbrain. Yeah.
Okay.
Am I audible, Dr. Deepthi?
Yes, ma'am. Yes,
Yeah.
ma'am.
Okay. Okay. So how will you manage this patient?
We will give for any MSA there can be some initial response to levodopa, ma'am. So we should give levodopa trial. If the patient is feeling better, we should continue with the levodopa.
What precaution will you keep in this patient specifically when you are prescribing levodopa?
Hypotension is the postural giddiness
Yes,
can
orthostatic
worsen.
hypotension
Yes,
is
ma'am.
there. Along with that, what happens in MSA in blood pressure?
Supine hypertension there can be.
Yes,
With
supine
levodopa.
hypertension is there, and that is a very important risk factor.
Yes, ma'am.
So that has to be carefully monitored.
Yes, ma'am.
Okay. And next, what will you do?
We should do look for any ultrasound abdomen for postvoidal residue, and for that also we should start if there is a postvoidal residue, we should give, and depending on the postvoidal residue, we can start him on. If it is more than 100 ml, we can start him on the oxybutynin these drugs.
Oxybutynin when you are having post-viral residual urine or when you are not having post-viral residual urine?
when we are having
Okay, what is the mechanism of oxybutyrate?
oxybutynin is anticholinergic, ma'am.
So what will it do?
So it retains so for urgency and
Yes.
urgent incontinence. Sorry, ma'am.
Yes, for
Overactive
urgency and
bladder in
large
case.
incontinence, you will go. So
Yes,
before
ma'am.
giving oxybutynin or tolterodine or any antimuscarinic agent or alpha-1 agonist, you must always rule out the post-void residual urine. It
Yes,
should
ma'am.
not be there. Okay.
Yes, ma'am.
And which, for example, if your patient is not having any this thing, post-void residual urine, so which anticholinergic agent is better to use?
Mm. Don't.
I mean, what is the side effect of these anticholinergic agents?
Retention, madam.
Which is like,
Urinary
no,
retention,
along with
blurring
the
of vision.
retention, yeah, along with the retention and blurring of vision, the important one is cognitive decline, or they call
Okay.
it impairment in cognition.
Okay,
Okay,
ma'am.
so out of them, oxybutynin is the safest one
Okay, ma'am.
if you want to go. That
Okay.
is which is available in India. Otherwise, your patient, if your patient is already having this cognitive decline, then you should be very cautious while
Okay.
prescribing these
Okay.
drugs.
Okay.
Okay. Other than that,
For if there is orthostatic hypotension, we can ask them to start having stockings along with that even with postural changes while getting up. First, he had to sit and then after few minutes he will stand. Even with that, if there is no improvement, we can start midodrine fludrocortisone.
so in orthostatic hypotension, you will go for a postural or rehabilitative management along with the drug management. So in
Okay.
postural reflex management, what we will ask, there is a 30-30-30 rule that is called
Okay,
as.
ma'am.
So in that, you
Okay.
will ask the person that before getting out of the bed, you will first move your limb or you will shake your lower limb while in the bed for
Okay,
30
ma'am.
seconds. Then you will
Okay.
hang your leg beside the bed and then you will shake them for 30 seconds and then only you will stand and then you'll start walking. Okay, this thing. Second thing, you will
Okay, ma'am.
ask them to, if they are having more gait instability, so it's better to advise them to use walker or some stick rather than just walking forward. And third most important thing, you will advise them
Okay, ma'am.
to be very cautious while in the night because they usually have urgency and
Okay.
that with the nocturnal frequency or
Yes,
nocturia.
ma'am.
So what happens that they
Okay.
suddenly wake up and start going and then they develop this syncope and develop SDH or this trauma to their head.
Okay, ma'am.
So that these three things has to be told in very particular manner to the family as well as to the patient. And after that, you
Okay.
will go for the drugs as well. And along with that, you will go for extra salt.
Okay, ma'am.
Okay. Okay. Anything else, sir?
No,
Okay.
no,
So
nothing. Anybody have any question they can ask? Can you repeat 30-30-30?
yeah, so 30-30-30 is a maneuver that is prescribed to this for autonomic dysfunction to this patient. We'll ask the person that before start walking, just to move, shake your legs, so just to move your lower limb while you are in bed for 30 seconds. Then to just hang your legs on the bedside and then to just move your leg to and fro for the next 30 seconds and then to stand and wait for next 20-30 seconds and then to start walking. So, because of this maneuver, then in case of early orthostatic hypotension or the thing, the person gets better, and there is a better reflex in this patient, and there's a lesser chances of syncope. So that was a 30-30-30 second rule, sir.
Yeah, okay, Dr. Soumya, we can conclude. You can give final comment, then we can
Okay.
close.
So, okay. Thank you, Dr. Deepti, for today's session. So, this was a
Thank
discussion
you.
regarding pyramidal and atypical Parkinsonism, MSA case. So, thank you, everyone. Thank you, sir, for today's session, sir.
Thank you, ma'am.
Thank you, Dr. Soumya and
Thank you,
Dr.
sir.
Vaishak for moderating this session. And thank you, Dr. Dipti, and everyone for attending this session. Thank you, Dr. Dipti. We can conclude
Thank you,
and
sir.
close. Thank you.